So thank you very much for the opportunity to be part of this meeting yet again, which is outstanding. And we continue with our theme of changing portraits in breast cancer and the interweaving of science and art. And Andy Warhol, the king of pop art, grew up very close to the NSABP headquarters in Pittsburgh today. And although he did have a series on the Mona Lisa, his Marilyn Monroes are so much more compelling, so I decided to show them instead. So I've been limited in the scope of what it is that I should address here to something that's concrete. I am not allowed to speculate relative to future applications, but really limit the focus of this discussion to what's available right now to the clinician that's useful. So have we approached the era of practical and applied genomics for clinicians that can be utilized today and not something that is a promissory note for that which can be used in the future? Now, certainly we have changed the portraits of breast cancer, and the randomized prospective trials have been instrumental in bringing about changing portraits in breast cancer. We have changed the standard of care from this portrait, using data from randomized prospective trials and the NSABP, to this portrait, breast conservation. But the question remains, have we crossed that elusive threshold of therapy based on empiricism, therapy based on phenomenology, to therapy that is based on well-defined molecular signatures? Now, we heard from Edith Perez that these microarrays are really not ready for prime time application because we have complex mechanisms. So the question is, can we apply any of this to the standard of care for our patients, not in the future, but for the patients that we're going to be seeing next week? So whenever one mentions the radical mastectomy and has the temerity to challenge it, and of course the retreat from radical mastectomy and the ascent of adjuvant therapy are inextricably intertwined, one has to pay homage to William Stewart Halsted. Invariably, we show a picture of the senior Halsted as a symbol of tyranny and authoritarianism that ruled with an iron fist and determined how breast cancer was treated for over a century. I think this is not fair to Halsted. So Halsted was once a young man. And I show this photograph of a young William Stewart Halsted to indicate that he was once vibrant, he was once curious, he was engaged, he was engaging. He was involved. So who is guilty of authoritarianism and tyranny? Perhaps we are guilty of the very traits that we accuse William Stewart Halsted of harboring. How did we treat breast cancer, node-negative breast cancer, 10 years ago? Well, let's examine the report of the august consensus panel of the National Cancer Institute. And the trials of the NSABP played a pivotal role in generating these conclusions. It is accepted practice to offer cytotoxic chemotherapy to node-negative women with primary breast cancer larger than a centimeter in diameter. Is this authoritarian? Is this tyrannical? We knew that all patients didn't benefit from chemotherapy. We simply couldn't identify them. So the conclusion was, treat everybody. And there was a codicil for women with lymph node negative cancers smaller than a centimeter in diameter. The decision to consider chemotherapy should be individualized. Individualized based on what? clinician bias, certainly not tumor size, perhaps age. So we were really very uncomfortable with this, even though we were responsible and played an integral role in generating these conclusions. So we made a concerted effort to try and develop a molecular signature or profile to change this status. And the NSABP developed a partnership with Genomic Health of Redwood City, California, to develop the Oncotype DX assay, initially for node-negative, ER-positive patients. And I think that this certainly is not the be-all and the end-all, but is it proof of principle that we can use a molecular algorithm to determine who should and should not be treated? We think the turning point for applied genomics really occurred in December of 2003 when Soon Paik, the director of NSABP pathology, shown here, presented the validating data for NSABP protocol B14 to some of his most intimate colleagues, associates, and coevals, many of whom he went out drinking with the night before. So here we see Soon Paik at tenfold magnification, still able to maintain his diminutive phenotype. He's not a very big individual. And I think that's obvious. So rather than going through the data, I will give you the conclusions first. And I can assure you that the conclusions we derived from NSABP B14 and B20 were neither reticent, nor were they recalcitrant, nor were they laced with a hint of humility. And I think some people resented the conclusions that we made. But I think that the conclusions are also indicative of the criteria that are necessary to apply an algorithm for the use on a practical level by clinicians today rather than in the future. So we stated that the 21 gene recurrence score, the Oncotype DX assay, can accurately quantify the likelihood of recurrence in node-negative ER-positive tamoxifen-treated patients. It was subsequently shown by Mitch Dowsett and Ian Smith that this also applied to aromatase inhibitors. The recurrence score performance exceeds standard measures such as patient age, tumor size, and tumor grade. If it didn't do that, then we would have an expensive assay that would simply duplicate what you can get from Adjuvant online by referring to that algorithm free of charge. The assay is practical and clinically applicable since it utilizes sections from standard fixed paraffin-embedded tissue using RT-PCR. The fact that it doesn't require fresh frozen tissue is attractive. It's certainly attractive to the surgeon. And as you know, surgeons are unable to delay immediate gratification for future gain. That's the way we are. We can't help it. Perhaps we are genetically encoded for that. Further, the 21 gene assay is also predictive of chemotherapy benefit. In node-negative patients, certainly, but the data from Kathy Albane that's just been published in Lancet Oncology would suggest that it's applicable to node-positive patients as well. So who has endorsed this assay, and does it matter? The fact remains that over 100,000 patients in the United States have had this assay performed to determine who ought or ought not be treated. It's estimated that 60% of patients who are node-negative and ER-positive have this assay performed as an aid to determine how they ought or ought not be treated. So, do we have the data to support these rather contentious statements that we made based on the data from NSABP protocol B14 and B20? So in essence, out of 250 candidate genes in the developmental phase, 16 genes were selected using univariate analysis based on their strong association with outcome using cluster and principal component analysis. They were grouped into 5 distinct categories: a proliferation group with 5 genes that are intuitively applicable, or intuitively they are concordant with our biases. HER2 group with 2 genes, an estrogen group with 4 genes, an invasion group with 2 genes, 3 genes without portfolio, and 5 reference genes used to normalize the data because this was generated from paraffin blocks that were stored for various periods of time. Each of these categories was then assigned a weight, shown here in descending order, but not in order of their importance, giving us 3 categories, which of course are arbitrary: a low risk with a recurrence score of less than 18, an intermediate risk, a recurrence score of 18 to 30, and a high risk group greater than 30. And taking this algorithm in its pure, unvulnerated state, we went ahead and tried to prospectively validate it from the specimens that we had in our tissue library for NSABP protocol B14, which randomized ER-positive, node-negative patients to either placebo and tamoxifen, and we used the tissue library from the tamoxifen-treated group, and the data were published in December of 2004 in the New England Journal of Medicine. This wasn't simply a prospective validation. We had the approval of 2 IRBs. The specimens were examined. They were licked. They were barcoded. They were fondled. And the link between the data and the specimens resided with a single honest broker who could put the 2 together, and that was the only person who was able to do it. Fortunately, we were able to recruit this honest broker from the controller's office of Enron. And to give you an update, he is now tastefully attired in an orange jumpsuit inspired by Karl Lagerfeld, with accessories by Marc Jacobs. So, we asked the first question: is recurrence score associated with outcome? And this is the data that we saw: disease-free recurrence survival with the tamoxifen-treated cohort without applying the recurrence score. 82% overall distant disease-free survival. Now, if we apply the Oncotype DX over this, we see that there is remarkable separation of the curves to a low risk, an intermediate risk, and a high risk cohort. That the absolute difference between the high risk and the low risk at 10 years is 24%, with a p-value that has lots of zeros after the decimal place, giving our biostatisticians an endorphin rush. What is remarkable, I think, about this analysis is that 50% of the population fell into the low-risk category. So how much more could they benefit with the use of adjuvant chemotherapy? And it was the data from B14 and B20 that drove the conclusions of the consensus panel. In a multivariate analysis, recurrence score was superior to age, tumor size, and tumor grade. And tumor grade is not very reproducible. If you take a group of 3 pathologists and ask them to grade tumors, the correlation is about 66%. I reviewed these data and I said, hey, I'm going to harass my pathologic colleagues, or perhaps my colleagues from pathology, to be more accurate, or perhaps both. So this is a slide that I showed. Now, perhaps we're not there yet, but certainly we are approaching this. And despite the cynicism that currently exists, I think we will see the day when this instrument is going to become obsolete in the characterization of breast cancer. How did my pathologic colleagues respond? Sadly, they responded in a hurtful manner. They were vituperative and vindictive. It's amazing how much they resist the development of genetic profiles. This is an H&E cross-section of my right amputated middle finger, and it came back, signed out as no pathologic diagnosis, please send more tissue, preferably his liver. Now, if they had a robust genetic algorithm, they wouldn't really need more tissue, would they? They would be able to make the diagnosis. So, recurrence score is used as a continuous variable to estimate individual patient risk. So here we have the recurrence score, and you can see that it is continuous for most of its course. We superimpose the risk levels, which again are arbitrary, low, intermediate, and high. And if a patient has a recurrence score of 18, that translates to a 10% likelihood of developing distant recurrence, plus or minus the confidence intervals. And that's how the assay is used today to make decisions relative to risk and relative to determining whether that patient should or should not be treated with chemotherapy, which came from the data from NSABP protocol B20. So, does recurrence score predict the benefit of chemotherapy? And to do this, we went to our tissue library from NSABP protocol B20, which was completed in 1993 and had close to 14 years of follow-up, where the same patient population, node-negative, ER-positive, was randomized to tamoxifen or to tamoxifen plus CMF-based chemotherapy. And we had 651 tumor blocks available in NSABP protocol B20. And this is the overall data that we saw when we compared CMF-based chemotherapy plus tamoxifen to tamoxifen alone. And you see that the absolute difference relative to distant recurrence-free survival is only 5%. And this is what drove the conclusions of the consensus panel, this difference of 5%. So now let's superimpose the recurrence score on this 5% difference. For the low-risk group, which constitutes 50% of this population, we see absolutely no additional benefit from chemotherapy over and above tamoxifen. For the intermediate group, well, there may or may not be an effect here because the confidence intervals are wide, but it is unequivocal that the greatest benefit from chemotherapy occurs in the high-risk group, with a recurrence score of greater than 30, where we see an absolute difference of 28%, which is highly statistically significant. It would appear that the entire benefit, or the majority of benefit, from adjuvant chemotherapy over and above tamoxifen occurs in the third of the group that has a high recurrence score. Looking at this with confidence intervals, the low risk, again, no benefit, intermediate risk, the confidence intervals are wide, and the high risk that has an absolute benefit of 28%. Absolute. The interaction between the recurrence score and benefit of chemotherapy is highly statistically significant. So we see an interesting phenomenon occurring in the United States, that as the use of the Oncotype DX in the blue line is going up, the overall use of adjuvant chemotherapy is decreasing, a phenomenon that we see for the first time. It is decreasing and hopefully targeted to that segment of the population that has the greatest benefit from adjuvant chemotherapy. So certainly, I believe this has changed the standard of care in the node-negative, ER-positive subset in the United States, with the drop in the overall use of chemotherapy from a large database. There are prospective clinical trials that are ongoing, the TAILOR-X, which is testing the utility and propriety of the Oncotype DX assay in a very large randomized prospective trial, the TAILOR-X, where those with a low recurrence score as defined by this protocol receives hormonal therapy and no chemotherapy. Those with a high recurrence score receive chemotherapy plus hormonal therapy. Those with an intermediate recurrence score are randomized to chemotherapy versus no chemotherapy. The trial has entered over 8,600 patients. You'll note that the sample size for the randomized portion of this trial has been increased to 7,000. Why? Because of lack of compliance with the randomized option. People know the answer, regardless of whatever profile you use. So does recurrence score predict the benefit of chemotherapy in node-positive, ER-positive patients? And we have some evidence that it is congruent with what we saw in node-negative patients from the data of Kathy Albane from SWOG 8814. And she took the two arms, tamoxifen alone, in node-positive patients versus CAF, followed by tamoxifen. They had 367 tumor samples in their tissue repository. This was just published last month in Lancet Oncology and was presented in San Antonio in 2007. And it seems that the low-risk group shows no benefit from chemotherapy if you look at it here. If anything, the tamoxifen seems to be doing a little bit better than tamoxifen chemotherapy. Intermediate risk group, again, the numbers are small, and it seems that the benefit is apparent in the high-risk cohort. What is remarkable to me is that how many medical oncologists in the U.S. are using this assay for node-positive patients, where I think the numbers and the strength of the data are far less than what they are in node-negative patients. But nonetheless, it's being used, for better or for worse. Certainly the Oncotype DX isn't the be-all and the end-all. It is not the Rosetta Stone. It is proof of principle. Surely there will be assays that are going to be superior to the Oncotype DX, and we look forward to the day when the Oncotype DX becomes an anachronism. There are many profiles that have shown association with outcome that are intriguing and interesting. Certainly the 70-gene mammoprint is something that's being assessed right now in a large randomized prospective trial, the 76-gene Rotterdam signature, the intrinsic subtype. I find the PAM50 rather intriguing. It is a 50-gene subset of the 2,000 genes used for the intrinsic subtype that has a 93% level of correlation. We look forward to further data from this PAM50, which if is proven and validated, would be available at very low cost to a great many individuals for application. And of course, the MINDAC trial, and I hope, Martine, I am not misrepresenting it, an extremely important trial, which I think everyone should support, which is designed to determine if the 70-gene profile is superior to the clinical algorithm as exemplified by Adjuvant Online. If they are low, if they're concordant, low, no chemotherapy is given. If they are concordant, high, chemotherapy is utilized. If they are discordant, therapy is selected either based on the clinical criteria or the 70-gene profile. I hope that I have described this in a reasonably and semi-truthful manner, but I'm sure you'll hear a great a great deal more about this during this meeting. So have we crossed that elusive threshold between therapy by empiricism or therapy based on well-defined molecular markers, or is it just a delusion that is based on hope without a semblance of reality? Well, you can make your own mind up based on the data that's presented. Unfortunately, this is just as true today as it was a year ago, which I think is not a good situation, but we don't want to get off on a tangent here since I've already gotten off on a tangent. For one, I believe that we have crossed that threshold. I think this really marks the era of therapy based on well-defined molecular signatures, and I think that this is irreversible. I think from this point on, we will view breast cancer as a different portrait, and a portrait that probably has a few heat maps in it. But the age of tyranny, the age of authoritarianism is not over. We have to guard our mechanisms with a great deal of zeal. We have the armamentarium to move forward. It is up to us to use it in a wise, definitive, and intrepid manner. Thank you.